Namaste, I am Dr. Ashish Shrestha, General Practitioner working at Wharton Academy of Health Sciences. The present society needs not only a doctor, nor it requires a doctor who knows competency, but it values a doctor who demonstrates competence. Competency is a characteristic of a health professional which consists of knowledge, skill, value, and attitude. Acquiring these values make a healthcare worker competent. Demonstrating these values make healthcare worker competent. This is what a society needs. This is a slide showing transition to the competency. So conventional teaching has a fixed length and variable outcome, while competency-based teaching has a variable length and a fixed outcome. So we are in the era where education are of fixed length. Therefore, we get variable outcomes. That means some of the trainees perform better and some do not. Those who do not do well are not poor performers, but they need longer time or more focus to achieve the competence. So down the line in their career, both good and poor performers might be performing equally, or maybe poor performer might be performing better. So therefore, competency-based education is ideally variable length but fixed outcome. But as we run program at a fixed length, it is necessary to know where the candidates are on the competency scale. So this is a comparison between the traditional system of teaching learning and the competency-based medical education. Traditional system is more on knowledge acquisition. However, competency-based education is more about knowledge application. Traditional system is a single measure. For example, student must pass internal medicine or general practice. However, in competency-based medical education, the traits are distributed throughout many subjects and there are multiple objective measurements. Traditional system depends upon certain pass mark and emphasizes summative assessment, while competency-based medical education requires to demonstrate competence in and emphasizes formative assessment. So this is a slide showing a traditional model. In traditional model, the curriculum drives educational objective and assessment, while in competency-based medical education, health need sets competency and drives curriculum and assessment. For example, if a need of health system is safe delivery and a competency required is cesarean section, the curriculum and assessment is designed to achieve the required competency. At PAHS, we follow these 8 core competency framework. Foundation of professionalism is clinical competence, good communication skill, and sound understanding of ethics. The pillars of professionalism is also known as attributes, which are accountability, altruism, excellence, and humanism. Accountability is being responsible for own action or behavior. Altruism is patient's interest guiding physician behavior and action. Excellence is continuous maintenance of knowledge and skill. And humanism is compassion, empathy, integrity, and respect. Patient-centered care means customizing care with respect to patient preference, supporting the patient, and involving family in the care. Scholarship is the process and method of knowledge sharing. It is about scientific communication and reflective critique. A good leader innovates, motivates, and prioritizes, which makes them different than a manager. There might not be a single spot where this quality can be tested. Student gets various opportunity to lead during the course of their study. The student should be able to give clinical reasoning for safe and best practices. The student should know pre and post procedural requisite for safe procedure. Communication is another competence framework which is tested through various domains. Various things were thought to be correlating competency. So these were time spent in residency, time spent in deliberate practice, witness performance in an exam, habitual performance in an exam, end rotation checklist, daily feedback, end of training certification, and multiple training assessment. However, studies show that time spent in deliberate practice correlates more than time spent in residency. Habitual performance is more important than witness performance in the exam. Similarly, daily feedback were more important than end rotation feedbacks. Value of competence-based education is on multiple in-training exam than one final exam. Now, how do we assess all these domains? To understand this, first let's talk about Bloom's taxonomy. There are various levels from memory to creativity in Bloom's taxonomy. Therefore, when we design assessment, we need to understand what we are assessing. Similarly, in skill assessment, we need to understand what we are assessing and where students are at present. Completion of mini CX and DOPS require to show the progression or maintenance of their competency. Therefore, 3 DOPS in each area are used in PAHS. This is a traditional PG assessment system where there is first year exam and then second year exam and high stake final year exam. However, in competency based assessment, there are multiple in training assessments. At PAHS, we see trajectory of the student using Milestone. This is a Dreyfus model which shows trajectory from novice to expert. When a medical student comes for a clinical rotation, they are novice and they gradually become advanced beginner. At the end of medical school, we expect them to be competent in those 8 core competencies. So when a PG student joins postgraduate program, we expect them to be competent, and by the end of their 3rd year, we expect them to be proficient. Therefore, DOPS and mini CX at PAHS is designed to measure this trajectory. This is a milestone that we use at PAHS. We have 4 descriptors which is divided into 9 Likert scale. For example, rating scale of 5 means a student can perform in simulated scenario, and 7 means that a student can perform in real scenario but with supervision. Score of 8 is given when a student performs independently. The milestone needs certain activities for it to be assessed. These are Entrustable professional activities. The student required to attain knowledge, skill, attitude to be trusted to independently perform the listed activities. So EPA is measured with the competency using a tool. So this is a relationship between the assessment and tool and the competency with EPA. This is a competency-based medical education at PAHS. At PAHS, curriculum is based on health requirement of the society. So health requirement of the society drives curriculum, and the assessment is driven by Entrustable professional activity. Entrustable professional activity is measured in the milestone, and this milestone is linked up with the accreditation system. These are the assessment form that we use at PAHS. Let's take example of DOPS. The first line contains date, year, and program. The student name to be written in a second line. As this is for certification, for authenticity, third line requires NMC number, which is followed by name of the evaluating department. After this, milestone is in the column, and the rows contain various items testing knowledge, skill, attitude, and practices. There is overall score in the last line. The student requires to achieve overall score of 8 to pass EPA. This scoring is independent of the scores in the rows above that. A student can have very good technical ability but not good preparation level. However, in overall, if faculty assessing the student thinks that student is competent based on other areas, habitual practices, and the student can still get the overall score of 8. This section is followed by area done well and the specific action that needs to be taken. This area will be helpful for the student for the insight. Finally, there is an area to put the signature of the assessor. This is DOPS that we use at PAHS. Here we write date when the DOPS was performed, the year of the resident, and the program. This will be followed by name of the resident and their NMC number, and this will be followed by the procedure what they have done. And in the column there is milestone. It ranges from 1 to 9, and in each row there are attributes that is to be tested, and the final one is overall score. And in this area, faculties will write what were the areas that were done well and what were the areas that needs improvement. And finally, in this area, the faculty will write their name and his or her signature in this area. So this is case-based discussion. This is similar to DOPS. So here a student will write date, year, and a program, and student's name, NMC number, evaluating department, and the clinical case. And similar to DOPS, we have milestone that will start from 1 to 9, and the descriptors of milestone is given here, and the area that will be assessed is given in a row. And after this, faculty will write the areas that was done well and specific things that needs to be improved, followed by name of the faculty who is assessing, and then signature of the faculty and the date. So this is a field note that we use in PAHS. This is for quick feedback to the students. Here, resident will write their name followed by date, and they will write a brief summary of the patient or the clinical condition in this column. This will be followed by their next step in learning. After they write their next step in learning, faculty will go through their next step in learning and give appropriate feedback in this area. Thank you.